السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم وأشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبد الله ورسوله. إحنا إن شاء الله we'll proceed for this Janssen Spot Symposium, which is amyloidosis, think amyloidosis, which is an entity that deserves to think about and find the updates. Actually, it's related to the previously ended session, which is the onconephrology that was specifically targeting the paraproteinemia and the plasma cell discreases. We're pleased and honored to have with us Dr. Ahmed ElKeraie, lecturer of hematology, Cairo University, and we're going to share roles in targeting amyloidosis. Dr. Mohammed.
السلام عليكم ورحمة الله، كل سنة وحضرتك طيبين. Thanks دكتور أحمد for the presentation. إن شاء الله دكتور أحمد هيكلمنا دلوقتي بإذن الله عن overview of amyloidosis. اتفضل دكتور أحمد.
السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم. أشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبد الله ورسوله. Well, I'd like really to continue on the previous very well organized session that was paraproteinemias and the plasma cell discreases by going on to one end, which have been made much easy because Professor Omar and Professor Lilian Gaber from States, they have paved the way for amyloidosis. But I'll focus on primary amyloidosis along with. The key message is it's an often missed diagnosis. Let's go through it, through a patient. This patient is 40 years old, is a real patient in our university hospital. He presented by fatigue and hypotension. He has chronic diarrhea, or he had chronic diarrhea and lower limb edema for 4 years. And the patient had an ultrasound that showed bulky kidneys with a steatocirrhotic liver. He had an endoscopy because of the diarrhea, chronic diarrhea. He had an upper and lower GI endoscopy that showed mucosal inflammation, non-specific inflammation, and it showed amorphous eosinophilic deposits in the biopsy. Unfortunately, it was not taken to the end of histopathological diagnosis at that time. Then, due to his neuropathy, he had as well an electrodiagnostic study that showed axonal sensory motor neuropathy affecting both upper and lower limbs. His urinary protein creatinine ratio was 5 grams and his proBNP was 3000. Serum protein electrophoresis at last was done and it showed an M band that was gamma globulin of concentration of 7 grams. And the bone marrow biopsy showed a plasma cell of 10%. And the flow cytometry, as you can see, positive for CD38, 138, and 56, and negative for CD19. The old biopsies, GIT biopsies, was stained by Congo red, and it was positive, and the patient was confirmed as well by a renal biopsy that was done before the result of the Congo red was out, and the patient was referred to the cardiologist to have an ultrasound, and it showed typical amyloid findings. Diagnosis of AL amyloidosis was established by immunohistochemistry that showed AL deposits in the kidney tissue, and he was admitted to the hematology department. He started a VCD protocol, and the patient shortly passed into septic shock, but he recovered out of it, and he's now waiting for the further management. This is a typical history of a patient who had long journey before the definitive diagnosis and is now suffering from the expected complication maybe for the rest of his life till he can get a definitive treatment. Let's go back in the history. In 1854, Rudolf Virchow, he was the first one to describe the deposition of protein in the tissue, and that was iodinophilic. And the name amyloidosis was started at 1866. And we all know that it's an essentially beta-bleated sheets of protein in contrast to the regularly folded protein. It's a misfolding of the protein with an amyloidogenic intermediate first, then the beta-bleated sheets later on to cause the classic amyloid fibrils. And as you can see that the production of abnormal protein can be acquired mutation, mainly by monoclonal B-cell lymphocyte proliferation or going to the plasma cell and thus secreting the immunoglobulin light chain with a limited proteolysis to this abnormally folded protein, causing an AL protein, which is the AL amyloidosis. Or it can be on the other way, a chronic inflammation that causes macrophage activation with interleukin 1 and 6, particularly in the liver cell, and a serum amyloid A would be increased, and again, limited proteolysis leading to AA amyloidosis. Other types of amyloidosis, mainly the transthyretin type, is mutation in the mutant transthyretin, which is at the pre-albumin, as you know, causing aggregation and a transthyretin amyloidosis as well. And these are the very famous type of amyloidosis, the AL and the AA and the AH and the AF and the transthyretin types, whether the wild type or the mild type. And there have been many, more than 20 and approaching of 30 type of amyloidosis in the literature, and many of these cause specific disorders. Some of them are progressively systemic, like the AL amyloidosis, and others are specific to specific tissues, like, for example, the neuropathies, the carpal tunnel syndrome, the Alzheimer's disease, the cardiac amyloidosis, the ALECT amyloidosis in the interstitium of the kidney and in the liver, and others. But to cut a long story short, these are the different types with the different deposition sites and the different clinical presentation. This is the most common patient complaint to a patient with a primary or AL amyloidosis. The patient would come with a fatigue, orthostatic hypotension, exertional dyspnea, and pedal edema, and the affection is widespread. You can find bruises in the skin, you can find nail dystrophy, you can find muscle weakness and affection of the muscle, you can find affection of the tongue in the form of macroglossia. The heart affection is widespread from conduction block and arrhythmias and heart failure, mainly of the diastolic type, HFpEF with restrictive pattern. Of course, the kidney is affected in the form of nephrotic syndrome mainly, and proteinuria and progressive renal impairment. The liver is affected, and the spleen can go into hyposplenism. And this is the main issue, that a patient suffers to be diagnosed with primary amyloidosis. Usually, the patient lapse of time between the starting of the complaint and the diagnosis on the average is 4 to 5 years, maybe, and on the average he would see 3 to 6 doctors and at least 3 subspecialties before he is diagnosed as a primary amyloid. So it's a disease that needs a high index of suspicion to be diagnosed really. And as you can see, this is the patient experience about when and how they were diagnosed. And of course, as you know, our main slogan, with all due respect to our dear hematologist, but our main slogan is, medicine is a branch of nephrology, not nephrology is a branch of medicine. That's why nephrologists can usually diagnose the basal. So usually we diagnose not only amyloidosis, but most of the types of plasma cell dyscrasis and paraproteinemia, and then we send them back to be fixed with our dear colleagues, the hematologists. And this is the extent of involvement in different organs. Cardiac involvement in primary amyloidosis usually amount to 75%. Usually presents by heart failure, arrhythmias, syncope, or even sudden cardiac death. ECG classically low amplitude, and the echocardiogram has a specific finding with enlargement of the septum and maybe the posterior wall and what they call it bull-eye appearance, and the pattern of refraction in the amyloid fibrils. Cardiac MR can be very sensitive and very diagnostic in this situation. Of course, we do not do endomyocardial biopsy in most of the cases. As you can see, we will look for more accessible and safer way to be biopsied in the tissues. The nervous system can have a peripheral symmetric lower extremity sensomotor polyneuropathy. It affects as well the upper extremities. Autonomic neuropathy is common, and the EMG showed the picture that we have shown early, axonal sensorimotor polyneuropathy. Soft tissue involvement causes carpal tunnel syndrome and periorbital burbra, and you know the term of raccoon eyes and the periorbital halo, macroglossia as well, and the renal involvement occurs almost in 3/4 of the cases with proteinuria and nephrotic syndrome as the main presenting complaint, and the gastrointestinal involvement can be a very pretty cause of disablement in this patient. There is usually a chronic form of diarrhea and a protein-losing enteropathy and malnourishment from the malabsorption. And these are the major type of amyloidosis, the AL, the AA, and the transthyretin type. And this is the type of protein deposited, light chain deposits, mainly lambda, as you've heard Professor Lilian, sometimes kappa, but it's mainly lambda. Amyloid A is secondary to chronic inflammatory conditions. Of course, FMF is very important in our region, but other chronic inflammatory and chronic infective conditions can cause, although these are regressing a little bit nowadays. And the disease etiology, as you know, AL is a type of plasma cell dyscariasis. As we've heard Professor Adam, the spectrum of these plasma cell dyscariasis or paraproteinemia or dysproteinemia. Specific feature would be kidney, heart, and liver affection. Median survival, as you've heard, is very poor, 1 to 3 years, although these have been changed and is changing nowadays, as we've heard from Professor Umar Abdurrahman, from the hematological perspective. And therapy is chemo or no chemo. This would be addressed by Professor Muhammad Abdul Qadir. But you can find that the immunoglobulin-related amyloidosis is the one that have the full context of the clinical picture. It is the one with the neurological, hematological, cardiology, hepatology, and renal affection, as well as skin affection and joint affection. So whenever you have the full prone picture, think about primary amyloidosis or AL amyloidosis. This is the flow chart that I'm not going to go through it, but it's very nice flow chart, and I would stress and overstress that you should not give up the diagnosis because you could not find the restriction, as was elegantly shown in the previous lecture by Professor Lilian Gaber. If you cannot find the restriction pattern, this does not mean that you don't have the light chain amyloid or the AL amyloidosis. You can do more digestion to the tissues by proteolytic methods, or you can even use mass spectrometry to diagnose the presence of the amyloid pattern or the amyloid light chain. But this is the practical. This is what we have in hand, and this is very important. Please, whenever you suspect a plasma cell dyscariasis, whenever you have an unexplained features that gathers many organs like cardiac, renal, hepatic, and others, do all these. Do the three of them all together. Do serum protein electrophoresis, and it's much more important than urinary protein electrophoresis. Go for the serum protein electrophoresis, serum immune fixation, and the free light chain. And the important thing about the free light chain is the percentage of affected to the non-affected chain. It's not the average, the absolute number, rather than it is the ratio or the difference between the affected and the non-affected chain that is not only in the diagnosis, but as well in the, as we will hear, in the assessment of the response to treatment, whether complete or partial or whatever. If you have all these, you have sensitivity up to 100% in some cases of multiple myeloma, smoldering myeloma, 97% in AL amyloidosis, if you have the three of them. So again, this is a very important message. Please do serum protein electrophoresis, serum immune fixation, and serum free light chain, the total and the split and the ratio to whatever suspected case of paraproteinemia. Biopsy, of course, is the gold standard. Usually we target the easy, accessible, less complicating sites, abdominal bed of fat, the lip and rectum, and we can go to the kidney, and it's easy to stain by Congo red stain. And please do not comment on a Congo red stain on light microscopy. This is inconclusive. You have to comment by the birefringence, that is apple green birefringence, by the polarized microscopy, and not the Congo, and as well you can use serous red, which is assumed to be less toxic than the Congo red, but it is the same. And as Professor Adam showed early on, if you did not diagnose the patient, or if you have an organ involvement that is not explained by the general diagnosis, or you're not satisfied with the diagnosis, go for the biopsy, go for the renal biopsy. But we usually avoid the cardiac biopsy, of course. And renal amyloidosis is not only, and this is a very important issue, it's not just the nodular glomerulosclerosis differential diagnosis of the Kimmelstein-Wilson and the amyloid and the advanced FSGS. It's much more than this. It sometimes is not in the glomeruli at all. Not all types of amyloidosis affect the glomeruli. For example, ApoA1 and ApoA4 amyloidosis are usually medullary amyloidosis, affecting the collecting tubules and the interstitium in this area. Other type of amyloidosis, like ALEC2 amyloidosis, which is common in Egyptian, as Wissam have shown us in the last meeting, is mainly interstitial and not in the glomeruli. But usually AL amyloidosis is affecting both the glomeruli, the tubules, and the interstitium with the Congo red positive material. Cardiac amyloidosis can be diagnosed easily by echo, by MR, cardiac MR, and it can be suspected by ECG and by the technetium pyrophosphate scanning as well. Hepatic amyloidosis is an easy, and of course the liver biopsy is much more accessible and easier than the kidney biopsy in relation to the complication, and can be diagnosed. And once you diagnose, I do recall Mr. Shortland from Sheffield back in 2000 that he had a biopsy, a renal biopsy, that was done by the nephrologist registrar at that time. And in the clinical pathological meeting, he told us, unfortunately, we did not have a kidney in the biopsy, it was a spleen. She targeted the left kidney, but she got a punch of the spleen. But the man said, we did not discard the biopsy. We looked after the spleen, and we find deposition, we stained by Congo red, and it turned out to be amyloidosis. So he diagnosed the patient out of a missed biopsy. I mean, you should never discard a tissue without complete study. And I think Congo red staining is a routine in all studies. Again, this algorithm is a brilliant one. It shows the major diagnosis tools to diagnose on the left panel here, to diagnose amyloidosis, starting from the serum immunofixation, the urine, and the serum immunoglobulin for light chain, and the echocardiography, the cardiac MR, and the technetium pyrophosphate, and all the other going to the biopsies all through. And then it goes as, when you diagnose amyloidosis, do you think it's cardiac transthyretin amyloidosis? So you would go in this particular pathway. If not, you would go for tissue biopsy. If the biopsy proven to be Congo red positive and having the AL immunohistochemistry subtype, which is available, by the way, and easy to be done, so then you confirm your diagnosis. If it is not revealed, you go for more sophisticated measures, maybe mass spectrophotometer or revealing technique for the antibiotic. And I will stop here, leaving the main issue about the prognosis and the management, which have been escalated too much in the last few years, to Dr. Mohammed ElKeraie, who will continue on, inshallah, by updating the management of amyloidosis.